Hi, and welcome back to the WHY-O-MYO podcast. This is Janine Stiene, your host, hoping to answer your questions about the who, what, where, when, why, and how when it comes to myofunctional therapy. Disclaimer. All content and details, as well as education shared on the podcast, are the opinions of the speaker and for informational purposes only. Please consult with a certified medical professional regarding any questions or concerns, as this podcast should not serve as a diagnosis or replace the information that you have received from a healthcare provider. During today's podcast, I wanted to focus on the benefits of an interdisciplinary team and an interdisciplinary approach. I am sharing an interview that we conducted on another one of our series called Talk the Talk. On Talk the Talk, we speak to many different professionals that are all part of that interdisciplinary team and that play an integral role in our patient success. This is not limited to medical or dental providers, but also includes cranial sacral therapists, dental hygienists, and many more. We all have a role. In this episode, we speak to two pediatric dentists that refer to our facility for our trademarked SPOT Myofunctional Therapy program and have witnessed the benefits of our program firsthand. These dentists are proponents of a myofunctional therapy approach and its role in dentistry, and actually have their own dental hygienists trained in myofunctional therapy on staff. We all have our place in treatment. Even if we can't treat everything, we then rely on the many dental and medical professionals, as well as an array of other professionals, including dental hygienists, for their opinion and differential diagnosis, just like they will rely on us as speech pathologists and myofunctional therapists in a similar way. I am a huge proponent of education, staying current with the most up-to-date research, and seeking out opportunities to learn from all other professionals. I like to learn their beliefs, their opinions, and approaches, especially when it comes to oral myofunctional disorders. In addition, I attempt to do my part by offering free lectures and in-services to any and all members involved in the field of myofunctional therapy, while also taking that time to explain how these individuals can best meet the needs of their own myo patients by employing their own resources. It is noteworthy to mention that every patient is unique and therefore requires a differential diagnosis to determine what type of intervention is necessary to best meet their needs. All patients with oral myofunctional disorders present differently and therefore require a different treatment approach. All patients with a tongue thrust are not always candidates for myofunctional therapy at that time. As part of our evaluation, it is necessary to ascertain why the patient is presenting in a certain way and devise a treatment plan that will best meet their needs. As an SLP, it is necessary for us to provide a comprehensive evaluation in order to make the best differential diagnosis. This may include ruling out motor planning deficits, texture and consistency aversions, auditory processing or fine motor issues, and any other underlying reasons for the deficits that they are presented with that may also not be related to a tongue thrust. I think we can all agree that the needs of our patients is always the priority, and that our patients should seek out the provider or providers that best meet their needs. Now, I hope you enjoy this episode of Talk the Talk. Good morning. Thank you so much for joining us. Today, we are with Dr. Mark Adelberg and Dr. Adam Postel, who are both known as Dr. Mark and Dr. Adam in their office. Thank you so much for joining us today. We just want to pick your brain a little bit about what it is like to be a pediatric dentist and some of the concerns or obstacles you find when you're dealing with patients. So our first question for you is, when is the first time a parent should bring a child into the office for their first dental appointment?
Well, first of all, guys, thank you for having us. It's a privilege and a pleasure to be on your webcam Zoom meetings, right?
Thank you. Thank you.
So this is not really a question that we would say. It's our academy. The Academy of Pediatric Dentistry recommends the first visit takes place at either 1 year old or 6 months after the first tooth.
Okay.
But I know eventually we'll start talking about growth and development. And so some might argue that even those dates are too late because there could already been some damage not done or some corrections that could have been made in that growth. But that right now, the guidelines are at 1 year old or 6 months after the first tooth, whichever occurs first.
Okay.
Okay, very nice.
Perfect.
And what about toothbrushes? So at what age would you recommend that we, go to a mechanical toothbrush or start using fluoride toothpaste? Are there recommendations on that?
Yeah, so we should start brushing the teeth with a toothbrush as soon as the first tooth comes in.
Okay.
In terms of fluoride toothpaste and or toothpaste in general, same thing. As soon as the teeth come in, we should be using toothpaste. It really depends on something that we call a caries risk assessment, which is also published by our American Academy of Pediatric Dentistry. For instance, for a family or child that is high risk, even at a young age, fluoride toothpaste in the proper amount is okay. But generally, the rule of thumb, until you have had a caries risk assessment, is a non-fluoridated toothpaste until the age of 3 and just a pea-sized amount.
Mm-hmm.
Okay. Does that include the Infident for those individuals? Would you consider the Infident an actual toothbrush, or does it need to be an actual toothbrush?
Yeah, either is fine. We just don't want the the washcloth or finger by itself approach.
Got it. Got it. Well, I'm sure you see that a lot, and we do as well.
And then you had asked, regular toothbrush versus mechanical and types of toothpaste. I mean, really, at the end of the day, you also have to worry about compliance. So, if your child wants to brush with Barbie toothpaste or Buzz Lightyear toothpaste, and it's going to make them brush more, we're 100% for it. So we have some families that are a family of 4, and they all have 4 different toothpastes.
Yes.
One likes gel, one likes paste, one likes baking soda, one likes strawberry flavored, whatever it takes.
Got it. Okay. We find a lot of patients have limited dental insurance. What types of things do you offer in order to manage some of those expenses?
So we do have a myriad of options. More recently, we've established a membership plan, which is great. It includes things like cleanings and checkups and discount on a whole bunch of work, including orthodontics and even a free sleep breathing consultation and evaluation.
Wow, that's fantastic.
Yeah, we recognize the fact that there are a lot of people out there who don't have insurance or have poor insurance, or perhaps they've even lost their job, et cetera, during, the pandemic. So our new membership plan, AMD Prime, allows you to pay for your checkups every month as opposed to, one big swoop. And it gives you significant discounts off of treatment to still allow your child to get the best care possible.
That's great.
That's great.
Mm-hmm.
That's one of the questions parents always are concerned about and asking, especially when it comes to follow through.
We're a customer service oriented practice, as we know yours is, because we share many mutual patients. And so, we always encourage people to call, and our receptionists, they'll call the insurance company and find out, almost, as down to the penny as they can, what the visit would cost, because we want to reduce the surprise for both us and the patient.
Absolutely.
Right. And probably like you guys as well,
Mm-hmm.
there are plenty of insurance companies that we may not be in network with. However, they have wonderful out of network benefits and still can enjoy almost basically the same exact care. They may very well have all their preventive care, exams, cleanings, fluoride, sealants, x-rays covered at 100%.
Okay.
And so they don't have to find that in-network practice that maybe is in Brooklyn and here they live out in Stony Brook and they go, we want to come to you.
Got it.
Great. As far as orthodontic consultations go, at what age are you usually starting to get your patients in those orthodontic consultations? Is it age? Is it more about what their mouth is looking like and, their teeth and all of that?
So now we're going to go down a rabbit hole.
Yeah.
So, a few years ago, I went to a symposium that was sponsored by the Academy of Pediatrics and the Academy of Orthodontics. And the general summary there was when a child's old enough to sit for records is probably when they should first start seeing the orthodontist.
Okay.
But as pediatric dentists, we clearly see these children well before most orthodontists would ever consider seeing them. And so we're already looking at patients from a very early age, determining, is there something we can do to change their facial structure? So a lot of people think it's just a matter of, are my teeth going to be straight, which of course, from a cosmetic perspective is important, but really the foundation of where those teeth sit, the bone, that's really the most important component. If you can get the bone in the right spot, then the teeth will soon follow. I mean, there are studies going on right now out in California where they're actually doing Invisalign on 2 and 3-year-olds because they realize the detriment that these patients have put themselves in. And they're really falling behind the proverbial 8 ball. So now it's like, can we get your mouth in a better position? Again, nobody's going to say, let's straighten a 2 and 3-year-old's teeth. It's let's put that 2 and 3-year-old's bone back in the right position. Because Invisalign locks into your mouth, you can get that done sooner. And that starts morphing into then, are there appliances that we can help change, the way you function, the way you breathe, maybe assist you guys with the way they're swallowing, because all of these functions will significantly change the way your face is going to develop. So, and honestly, when people ask about orthodontics, again, orthodontics encompasses so many different things. So, the orthodontic process is probably a better question. When should the orthodontic process start? And so when the evaluations start, is it a palate expander? Is it a growth and development device? Is it an airway breathing device? Is it, hey, we're just going to move a few baby teeth out of the way to facilitate the growth of adult teeth, even though we have no plans on putting you into any sort of braces, brackets, wires, etc., that you guys might remember. Right. But there has to be a paradigm shift now amongst parents, because most of us, and I know I'm a little older than you guys, but most of us would remember that our friends started braces in the 6th or 7th grade, and we're not going to start braces until all of our permanent teeth have started to come in, or the other side, our baby teeth falling out. Yep. And that's a very, very old school way of looking at things now. So we really try to push early intervention, because early intervention only works best when it's done early. That's the whole portion of early intervention. And much like, when we were growing up, we never heard of a child going in 1st and 2nd grade to get, reading or math help or even speech in your guys' world. And now it's commonplace. Kids are being pulled out of school all the time for a myriad of things. And we're basically saying, we're going to pull you out of your school to get, some growth and development done. And that's the way we look at, orthodontics as a whole.
Yeah, one of the nice things about our practice, and there are many practices like us where we have an orthodontist in the office, with us quite frequently. And so it's pretty easy to get the orthodontist to swing on by when the child's in for a dental checkup and say, hey, what do you think? But like Dr. Mark said, I always, caution parents, just because they're going for an orthodontic evaluation does not mean they're getting braces or Invisalign, right? We want to all work together to get the child to grow and develop as well as they can, and really get to their fullest potential at the right time. In the orthodontics world, there are certain things that you can do at any age, but there are certain things that you can't. And there are certain things that happen easier from an earlier age. So we want to be cognizant of that, and timing is really key there.
Absolutely.
Okay. Is there any correlation between getting teeth early and losing your teeth?
There could be.
Okay.
Most people who get their teeth early, more often than not, have more space in their mouth.
Okay.
So it's easier for the teeth to grow in.
Okay.
And then subsequently, it'll be easier for the permanent teeth to move into the right position. But it doesn't have to be that way. But there is a strong correlation where, on the opposite side, when a mother will say to us, little Johnny's 7 years old, he hasn't really lost any of his teeth. Most of his friends are losing teeth. And we'll say, well, now this patient, as we said, should have come in at 1 year old, but they didn't. So now we're seeing them for the first time at 3.
Yeah.
Or we saw them at first time at 3. So we don't have any record of when their first tooth really came in. And so we'll say, well, let's go back in time. At his first birthday party, do you remember if he had any teeth? You say, oh God, no, he didn't have any teeth at that time. And we were wondering back then. So you get your teeth late, they usually fall late. You get your teeth early, they usually fall out early. But that doesn't have to be the rule, but it seems to be, a correlation, I would say, is a correct way.
Okay, that's good to know.
So obviously we have a lot of patients with special needs, and I know that you guys also will see patients with special needs. So what does a dental visit look like or what can a parent expect when their child with special needs is coming in for their first dental visit?
Yeah, it's a great question. So there's definitely no cookie cutter approach. And it's important for people to realize that as pediatric dentists, we went to 2 years of specialty training after dental school to learn about treating children, but also under our scope is treating children with special needs. So this is very much in our wheelhouse, and we do this every day. It really starts from the first time the patient comes into the office. So, you know that you've been in our offices and they're themed like amusement parks, as we like to say. So right off the bat, the child doesn't, associate it with, going to the pediatrician and getting blood work done or going for a strep test or anything like that. We really feel each child out. So some children are better served in a private room. Some children are better served in an open room where they can see other children, feeling comfortable getting their teeth cleaned or their teeth worked on. So we have both options. There's a lot of desensitization. I mean, for severely special needs children, we have some patients that come to the office multiple times, and maybe the first time they'll take a ride on the chair, or the second time, we'll put the mirror in their mouth. Sometimes we'll even give the parents some of the tools that are safe for them to bring home to say, hey, you can give this to, Johnny or Mary, and you can play around with this at home, and you can even bring it here so they feel like they're bringing their own tools back to the office. Those are just a few things that we do. But again, this is not a once in a blue moon thing for us. This is an everyday, occurrence. And we don't have a cookie cutter approach because each child is different in their special needs.
Yeah.
And I would add to that as well. I mean, you guys, when you say special needs, the word really there is special. So each child is going to be special, and special needs can encompass so many different things. Is it autism? Is it Down syndrome? Is it diabetes? Is it a rare syndrome that, it wasn't one of the ones that showed up frequently on our board exams? And so,
Yes.
so we go in, we research, we find out if there's going to be a dental anomaly associated with that, et cetera. And, even two people who have the same diagnosis can be very different. You can have, a child who's autistic, who's nonverbal, and one, who, is high functioning, and their approaches may be very different. And the reality is with children, you treat one child at 10 o'clock in the morning, that same child next week at 4 o'clock in the afternoon, and they could be very different on those 2 different days.
So true. Yep. So true. Absolutely. We see that often too with the time of day that they're being worked on or getting therapy. All right. So as a dentist, this is in our wheelhouse. How do you rule in or rule out a tongue thrust?
Well, Adam, you're one of the guys who does our tongue releases. So.
Yes, let's hear it, Dr. Adam.
So, I mean, there's many things that we could look at. Sometimes, honestly, it's a referral within our house by the orthodontist, and we can see some flaring of the front teeth. So then we look to see if there are certain signs and symptoms. We have the patient speak to us, or we just evaluate them as they're sitting there, because a lot of times as they're, swallowing the toothpaste, they're pushing their tongue forward, or as they're speaking, they're pushing their tongue forward, or whether they're just sitting there, they're pushing their tongue forward. But a lot of times it's what we call the architecture of the teeth that give us as the dentist the first telltale sign. And then of course, we will refer them over to you and we'll say, can you please confirm this? And, can we possibly do some myofunctional therapy, in order to help to alleviate the habit? Because from an orthodontic standpoint, we always say, the braces can put anything anywhere. But if you take the braces off and you don't, eliminate the tongue thrust, you're just going to be back in the same position you were, which is, flared teeth. So those are some of the easier signs. I'm sure you can give us 150 more difficult signs that we can, improve on identifying as well.
What are the parents typically like when you're explaining this to them? Do you feel that they look at you like you have 10 heads, or do they seem like, okay, that makes sense, and that's something we want to pursue or want to consider?
So, it's a great question. And, as speech therapists and as pediatric dentists, or any really profession in general, we're always learning, and there's always new research coming out, and we're always going to courses. And I think that's certain things that set your group and our group, apart from others. We've seen you on the lecture circuit. You've seen us on the lecture circuit, and we're always trying to identify, new things to help our patients. So where we'll get the, I'm not, it's interesting that you bring that up, is for a patient who's been coming here for 6, 7, 8 years, and we haven't said something to them in the past, but now we're saying something, at this visit. And that's because honestly, we're continuing to learn. and we're continuing to see so many things that really can help our patients that we're interested in doing to help them, that's kind of when we get the, well, this is interesting that you bring this up. But I think for the most part, a lot of parents, with breathing and airway and myofunctional therapy and tongue, the cool thing is it connects a lot of dots for them. So we'll say, this is why I asked this question, or does your child also do this, or do they also have that, or they've been a picky eater. I understand you might have thought it was behavioral, but actually when I look in their mouth and I see their tongue is tethered to the floor of their mouth, they can't eat the hot dog with the bun properly.
Right.
And so I think that a lot of parents are thankful, but it does take a little bit of explaining. And then we always want to, validate our concern. And that's why we'll work with a myofunctional therapist, a speech pathologist a lot of the times, because this is a multidisciplinary team approach. Even on our breathing side, it's not just us. It's, sometimes the ENT, sometimes the pediatrician, sometimes the sleep medicine doctor, myofunctional therapy, all that kind of stuff.
That's great. I think that's the best approach it's an interdisciplinary approach. That's the best way to put it. And I think as parents, they definitely take your opinion and value your opinion as the dentist significantly. They really put a lot of weight into what you guys have to say. So it's wonderful that they're getting that education from you and not just once they get to us and now the education's coming from us.
And I think that it's great too that we're getting, especially from you guys, getting a lot younger too. So it's nice to get that patient from the pediatric dentist, even more so than the orthodontist, because we have more time and just like that early intervention that we were discussing.
Yeah, absolutely.
I know you mentioned a little bit about the tethered oral tissues. So if we can go into that a little, what is your role as pediatric dentist in identifying it, assessing for, remediating those tethered oral tissues within the mouth?
I'm going to still defer to Dr. Adam as our
Dr. Adam, you're on the hot seat.
First of all, it's interesting. In our practice, we've been looking at this, way before, 4 or 5 years ago, it was brought up at the American Academy of Pediatric Dentistry, because for 15 years, we've been using lasers in our practice, to provide no-shot laser dentistry for a lot of children. And we've done, many maxillary frenectomies and also some lower lingual, that's the tongue tie frenectomies. Over the past few years, a few of us in the office have really, taken some significant continuing education with some of the leaders in the field. Richard Baxter wrote the book, one of the books on tongue ties. Sarush Zaghi is a medical doctor, ENT, with the Breathe Institute. And so, as with everything in our practice, we always want to use the best technology and techniques. So we do use the light scalpel carbon dioxide laser, which is, in my opinion, the best in the industry, to release the tethered oral tissues on anything from an infant with a mom who's having trouble breastfeeding all the way up to some adults in our practice. But as you know, we are some of the stubborn pediatric dental offices, and will almost refuse to do the procedure if it's not coupled with myofunctional therapy. And so I know we've had many conversations on the phone, and I'll always tell a patient, you would never go for knee surgery, shoulder surgery, elbow surgery without physical therapy before or after. I might be diminishing what is happening at myofunctional therapy by saying that, but that's the analogy that patients can really relate to. And so, here we are having this tongue tethered for a long time in the child's mouth. They're not going to know what to do with it when I release. So they need to be prepared to do those exercises and get that tongue to its fullest potential. The tongue is one of the strongest muscles in the body. So, we need as much therapy as we can have before and after in order to provide the most optimal result.
And to add to that, even though Dr. Adam is really more of the tongue guy in the practice, clearly I do a lot of these evaluations as well. Our challenge, to tie it into one of your questions before, was, what's the parent's response? We do this because one of our challenges, quite frankly, is with some pediatricians. The pediatricians, they will classically say, only if the tongue tie is to the very tip is it something that's, a worry if the child's not, eating properly or speaking. And we do realize that that is not probably the right way or to approach it, because you can have one of those mid or posterior tongue ties, which is a little more difficult to assess. And so when I see those, those are the ones I say to the parent. I ask them a few questions and what can they eat and swallow and breathing. We're looking at the sculpture of the palate. And then I say, best that we have you guys evaluate these patients to really see if this is one of those more difficult tongue ties to evaluate. And if so, start with your treatment. And then if you guys feel it's appropriate, we'll release it for you.
Yeah, the other quick thing I'd like to add is, sometimes we run into confusion or difficulty. Not every speech language pathologist is trained in myofunctional therapy. So sometimes we'll bring something up to mom or dad about the child in the chair, and we'll say, I think that this is worthwhile of an evaluation for a possible release of the tethered oral tissue. And they'll say, well, I asked their speech pathologist that they go to outside of school or in school, and they said, well, we're not really sure. And, the same way that there's different specialties in dentistry, right? I don't know, the ins and outs of placing a dental implant because I'm not a general dentist, oral surgeon, or periodontist. Not every speech language pathologist is very well trained and educated on myofunctional therapy. So that takes, a little bit of education and understanding for the parent that, here is this person that's helping their child in school or outside of school that they trust, and they're amazing. My wife happens to be one of those speech language pathologists who doesn't, just myofunctional therapy is not something she's trained in. And so, we need to make sure that they're seeing you in order to really become educated and then make their own educated decision. It's like any other, healthcare decision that they'll make. But that is a hurdle that we're working on educating patients about.
That's fantastic. One of the discrepancies that we do get when we are referring has to do with the labial frenum. At what point should a labial frenum be released? Some say or tell us that it's post-orthodontics. Others say pre-orthodontics. I feel like our heads are spinning sometimes, even in the lectures that we participate in, the same thing.
So we'll make it really simple for you, okay?
I'm
the
ready.
Ideal time to have that lip release is within a few days being born, okay?
Oh, okay.
Ideally, but not every child's going to do that, okay? And so at that point, we start evaluating. The reality is the biggest problem usually is more cosmetic with the labial.
Okay.
Some moms will say latching on is the problem, which is why I would say when they're a newborn. But if there's no problems from that point forwards, we usually would do that labial release between 6 and 8 years old. So we want to get rid of that tissue. And by the way, you have to make sure that you go down to the bone of the periosteum, which is where a lot of doctors who treat this, they snip it they didn't really get all the fibers out of the way. Okay. Because then between 6 and 8 years old, as the front 4 incisors, the front 4 teeth, for those who are a little bit more on the layman side, we want them to naturally drift together. Now, the reason why there's some confusion is because probably to this day, most frenectomies are still done by scalpel or scissor. We haven't done one like that in 17 years now. We've been using our lasers for that. And with lasers, there's no scar tissue. So when there's no scar tissue, it'll allow these teeth to drift together. If, however, using a scalpel or a scissor, you're going to create scar tissue. So what's the point of replacing this thick, fibrotic muscle in between your teeth with a thick, fibrotic piece of scar tissue? You would never do that. So old school orthodontics would say, let us bring the teeth together, and then you can cut out whatever you want. And who cares if you create scar tissue at that point? The teeth are together. But if you use the laser, there's not going to be any scar tissue. Those teeth will be able to drift together. And I got to tell you, if that becomes the only thing that somebody needed for braces, often they will no longer need braces.
Okay. Okay. And that's good to know. I feel like that message is not consistent across dental practices. Is there any screening that a pediatrician, or say you had mentioned doing it right after delivery or during infancy, is there any tethered oral tissue screening that pediatricians are doing that you know of prior to those patients coming to see you guys as the pediatric dentist or as the speech pathologist?
So it's interesting, as I'm sure you both know, in Brazil, this is one of the only countries in the world where it's a requirement to be discharged from the hospital. It is not like that in the United States of America. And, we work with many pediatricians in the area, and, some do a great job of screening for it, particularly if mom is reporting a difficult time latching to breastfeed. But other than that, there is no standard that we're seeing. Although I would love, as I'm sure you would, for the push in the United States of America as we, are on the forefront of healthcare on almost, everything, it would be nice to, put our name next to Brazil on that.
Agreed.
Absolutely.
Agreed.
I guess fortunate or unfortunate thing about living in a very developed country is that we have ways of getting around tethered tissues.
Mm-hmm.
So, if 1,000 years ago, if you couldn't breastfeed, you wouldn't live. Failure to thrive, you would die.
Right.
I know that sounds harsh, but that's the reality of it. Okay. And somewhere, someday ago, some very, very smart woman with a really sharp fingernail went, let me just pull up that and cut, right? And it's by today's standards, that's crazy. But those children, somebody figured out, if I could just get that tongue to work a little bit better, we'll be able to get you to breastfeed. Here, if you're having problem breastfeeding, we'll give you a bottle, we'll give you this, we'll give you that, and they'll figure out ways around it. And so you can have tethered tissues and not realize how detrimental those tethered tissues are to your growth and development. Yes, you're gaining weight, you're developing, but you may not be developing along the exact trajectory that you were intended to.
Okay. Mm-hmm. Yes, and exactly, that's exactly what we see the same things as well. Even just the impact it has on the airway, the resting posture, what it's doing to the palate, all of those things have an adverse effect for us in terms of speech, and especially as myofunctional therapists, which I'm sure you guys see a lot of that as well. So I'm going to do the next one. You want to get it?
So I know that we see a lot of patients who come to us with thumb sucking, finger sucking, prolonged oral habits. And I'm sure you both have patients coming to you and seeing the same thing, whether it's their thumb sucking, finger sucking on a pacifier still. So what is your role? And you're often seeing these patients before us because maybe they don't have speech issues yet. So what do you say to parents when their child is coming in and you're being reported of or noticing the prolonged finger sucking?
I'll say the PASI is a 4-letter word in our practice.
Okay.
So, there was a study that had come out of maybe 15, 20 years ago that talked about pacifiers and perhaps preventing SIDS. And the theory was they don't get into deep, stages of sleep. And this way they're easily irritated and more easily aroused. But breastfed babies also are more easily aroused and also much less likely to develop SIDS. And at the same time, they're developing very differently. The compression of the tongue against a mother's nipple compared to a pacifier is incredibly different. The compression of a mother's nipple compared to a bottle nipple is incredibly different. So I urge moms, especially those who are in the practice who, they're telling us, the older sisters in the chair, tell Dr. Mark or tell Dr. Adam what's going to be happening, in August. Oh, we're going to be having a baby. I'm going to say, listen, I'm just going to tell you what the guidelines are and what the suggestions are. I'm not going to tell you how to parent your child. That's up to you. But I would basically say if you could do your best to get rid of the pacifier or never start one, you're better off. Okay. However, if you do want to subscribe to this may prevent SIDS model, the model still is after 6 months, you're supposed to get rid of the pacifier. But of course, at that point, both the children and us parents, because we're parents too, we're not just doctors. We all become addicted to it, and then it's really hard to get off of it. So I would say, don't start a habit that you can't get rid of. That's awful. As far as fingers and thumbs, that's a very different conversation because most moms can pull out their sonogram pictures and be like, look, you already got the thumb in there,
Yeah.
And, that's a way more difficult habit to break. We try to encourage them to keep pulling it out. There are definitely old school thoughts. There are some, like hard fast, like we paint yucky stuff on their thumbs or Tabasco sauce. And, we're certainly not in favor of your child becoming injured. I think most studies will say negative reinforcement isn't always the best, but it's also hard to say to a 1-year-old, hey, if you don't put your thumb in your mouth the next 5 minutes, I'll let you watch, 20 more minutes of Sesame Street. That part doesn't connect.
Yes.
But there are items that you could buy on the internet, and I'm not going to endorse any one product, but that allow you to kind of block the thumb. There are thumb guards there. You can even really just go old school. And we tell people you can even put a sock on your child's hand and, a little bit of duct tape, not so much that you cut off circulation, but that they really can't get their hands in their mouths. You can do ace bandages on the elbow. I've even had patients who back in the day when rollerblading was very popular, they would put the rollerblade heads on their elbow, but they would turn them around to the hard parts on the inside. So it's hard for them to move.
Yeah.
And truthfully, there's also a difference between daytime sucking and nighttime sucking. Daytime sucking, you have some control over.
Yes.
You can watch your child. You can, you can sit with them and you can say, hey, listen, I know you want to suck your thumb. Okay. And here are the triggers. Every time we sit on the couch and you hold that blanket and Sesame Street goes on and you start curling your hair and the thumb goes in, I'm going to let you suck your thumb today, but not for the first 5 minutes. Let's put a little timer on the table. Let's get the 5 minutes. We get the 5 minutes. Go ahead, go for it. And then tomorrow we're going to work up to 7 minutes and 10 minutes. And we're going to try introducing stimuli that makes you want to suck, but also remind you that you're not supposed to, and build up to that. But now you're into like child psychology stuff. And that is very difficult to, my bachelor's degree in psychology only gets me so far.
Yeah. The interesting thing is a lot of parents will say to us, let's say they're coming to us at 4 or 5 years old for the first time because they just moved from out of state. They'll say, we'll ask them on our questionnaire. And that's, again, one of the importances of coming early is we can educate the parent early. They'll say, well, they only used the pacifier until they were 3 years old. Well, we all on this call know that, 55% of the facial development is done by the time we're 2 years of age. Or we'll have a parent that says they only, suck their thumb at night to fall asleep. Well, there's 3 factors in terms of how it affects the orofacial musculature and structure, which is duration is one part of it, but intensity and frequency is the other 2 parts of it. So if 7 nights a week they're doing this and they're a really intense sucker, it might be worse than passively keeping the mouth in for 3 hours during the day, instead of just to fall asleep at night. So it all comes down to education and, helping the parent with some strategies. And it's like anything else, right? In order for myofunctional therapy to work, the parent has to be on board. They have to help with compliance. It's the same thing here. So it's more educating the parent than working with the child because it needs to be a team approach here.
Right. Absolutely. We have a lot of parents that will tell us, I'm not ready for them to stop sucking. So then if they tell us that, we know we're done. We have to wait until the parent is on board to help the child stop. We can't do it in a vacuum with just the child if the parent's not ready to support that, the habit being broken, which we do find that a lot. And I think that the same thing, the quicker we can get that finger, thumb out of the mouth, the better off the patient will be long-term when it comes to just the overall shape and of the mouth, as well as the teeth and the overall occlusion. So obviously you guys have been amazing and refer a ton of patients to us for myofunctional therapy. What are some of the things that you see when your patients are going for myofunctional therapy and the impact that it has on some of the work that you may need to be doing or are doing with regards to their occlusion?
Well, I'll give you a great example. Our orthodontists, we've been preaching to them about myofunctional therapy for quite some time. And just the other day, my orthodontist says, I had a child whose front teeth flared. And every time we took the braces off, they pop back out. We put them back on. And then there's this fight of who's wearing the retainers and not. And I've heard you guys preach now for a few years about the beauties of myofunctional therapy. So we started myofunctional therapy, and the girl came back, and her teeth are no longer flaring forwards.
Oh, that's great!
Yes, right?
Okay.
Muscle trumps bone, and so if you don't correct the tongue, you're not going to be able to prevent the occlusion from flaring out. That's the easiest thing to pick out.
Okay.
The harder things to pick out are, what is it really doing for airway? What is it doing for the roof of your mouth? What are the complications associated with airway? And so when, again, to tie in some of your other questions, when should you start? What are some of the things we're seeing? We often, Dr. Ab and I will ask, are there any medical complications associated with the way your face is growing? And so, when that mom, you just said, well, I'm not ready to give up the pacifier just yet. So that's okay. At what age would you like to have your first ENT surgery? And they're like, what?
Ooh,
because you're way more likely to have tonsils, adenoidectomy, sinus surgeries, tubes in your ears. Those are all ENT surgeries.
Yep.
At what age would you like to have your first surgery? At what point do you want to have your child being pulled out of school because maybe they're falling behind on the academic chart because they're not getting good night's sleep, their oxygen levels are dropping in the middle of the night? At what age would you like your child to stop wetting the bed? At what age would you like to correct the ADD or ADHD-like habits? Right now I'm driving to work, and what do I see all over my car? It's covered in green pollen. So if you're a mouth breather, all that pollen's going straight into your lungs. Would you rather, be filtered through your nose and humidified and go down and properly, as opposed to, breathing in all this junk or irritants? I mean, I don't know how long this video will be on, YouTube, but hopefully forever. But at some point it's going to look back and they'll probably say, even like, did you guys film this during the pandemic? And as Dr. Adams is wearing a mask and I'm not, I mean, yes. And so there's a lot of research coming out now that suggests that you were probably less likely to develop COVID if you were a nasal breather than a mouth breather. And so, the ability to breathe through your nose versus your mouth is really important. From a cosmetic standpoint, having high cheekbones and a chiseled out lower jaw is really what we find attractive, because the body has a subconscious thought process of, that's the type of person I'd like to procreate with. They're going to be healthier offspring. If you go off to the mall and you look at, photos and pictures that are the models, they all have similar looks. If you look at world-class athletes, for the most part, they have high cheekbones and lower jaw and lower chiseled out jaws, because they breathe better, which their bodies mean they act more efficiently and properly. So, I mean, I've probably gone off on a significant tangent. I don't even remember your original question, but I think you asked, like, what do we see that's better?
Yes.
So there's no question, when we start doing treatment, whether it's orthodontics or airway, or truthfully, even cavities. Okay. I mean, there's a lot of evidence out there that shows if you're a mouth breather, you're way more likely to develop cavities. You'll have a drier mouth. The bacteria will flourish differently. We see drastic improvements in all these things, because let's face it, the body is one unit, and it's, you affect one part of the body, it's going to have an effect elsewhere. And everybody wants to have a perfectly functioning body. Good luck. I mean, as I'm sitting here, I got my legs crossed, and I'm supposed to have my posture straight.
Me too. I was thinking the same thing. Yeah.
But that's really the goal. And so, it was probably about 10 years ago when I got diagnosed with celiac that I had a paradigm shift in my brain that I needed to look more into functional healthcare. And I don't poo-poo Western medicine at all. I mean, God knows, we're right there with many doctors working on plenty of things with my own patients or in my own family. But there is absolutely has to be room for Eastern medicine as well. And so sometimes parents hear some of this stuff and they go, well, that's just crazy. You just told me that you can prevent my child from having, ENT surgery, or you can fix their ADD, ADHD. And maybe we can, okay? And that it may be myofunctional therapy. It might be sleep and breathing. It might be chiropractic. It might be acupuncture. It might be cranial sacral. There are so many modalities out there that will lend to getting you better and making you feel healthier. And at the end, really, if you don't have your health, what do you have?
True.
I mean, ask Steve Jobs how much money he had. Did it make a difference with his pancreatic cancer? It didn't.
No.
And now, I'm not saying that myofunctional therapy and breathing is going to save you from pancreatic cancer, but my point is, if you don't have good health, you have nothing.
Yes.
Yeah.
So true.
Mhm.
So true.
Absolutely. So we know your practice is very myo-minded. Do you find that at this point, most pediatric dentist offices are well informed regarding myofunctional therapy, or are you not seeing that universal at this point?
I think there's more awareness, but I think we have a long way to go. I think we're at the beginning stages. Our practice is really almost always on the forefront of technology and procedures. So I know if, we're in our, infancy stages of it, 4 or 5 years of really understanding this and really getting much better at it and identifying that, the rest of the country is probably a little bit further behind, but there's definitely more awareness because we're seeing, more courses given and more chats about it on Facebook groups and all that kind of good stuff. So I definitely think we're on the precipice of something really good.
Mm-hmm.
We could definitely see that it's the understanding and the chatter about it has definitely increased significantly over the last few years as compared to when I started doing this. There was almost like the hex on me, what type of therapy are you doing and why are you doing that? We definitely see that there's more research coming out as well, especially in the United States, not just coming out of Brazil, which I think is also helping for people to have a better understanding and maybe be able to commit to the theory or the mindset of working with a myofunctional therapist to make a difference. One of the things we see a lot are children that clench or grind their teeth. Is there anything that you would recommend or anything that you do when you are seeing that with some of your pediatric patients?
Well, I think they absolutely have to have an airway assessment.
Okay.
Most people, we don't know, let's say many people who clench and grind, and certainly at younger ages, it is the body's way of trying to force their mouth open. And so it's predominantly happening at night, and the muscles are trying to fire, and you're clenching, you're trying to do this to open up your mouth. It doesn't mean that's the case with everybody.
Okay.
There's also some children who they're feeling some growth happening underneath the bone, and it's kind of like almost like a subconscious itch where they're scratching some of those teeth below the surface. Okay. So I don't want everybody who hears this and says, oh my God, my child's clenching and grinding. They potentially have a dangerous situation going on, but it's certainly worth looking into. So I think it's worthy of an assessment. And even if they don't go through a very formal assessment, there's many things that we could start looking at. Do they have those bags under their eyes, what we call venous pooling? What's the shape of their palate? There's something called Mallampati scores, which you guys know, but for the general public, it's essentially when somebody just sticks out their tongue, how far can we see down their throats? And these are all signs of inflammation in the back of the throat. So these are very simple and easy things to look for. But I think that when you look at the amount of people who do have some sort of tongue-related, sleep-related, breathing-related problem, the percentages are exceptionally high, especially given the fact that the percentage of people who have used artificial devices, whether it be pacifiers or bottles, are going to be more likely to head down that path. So if you have a child who has had finger, thumb, pacifier, and has been predominantly bottle fed, and now you're seeing clenching and grinding problems happening, more likely than not, they should be assessed.
Okay. Do you find that the airway assessment, you had mentioned that you guys will do an airway assessment. Do you find that that is happening with all pediatric dentists? Is that a standard of care?
Oh God, no.
It's definitely not a standard of care, no.
Okay.
No, I mean, the company that we trained with back in 2019, we were the only pediatric dentist on the entire East Coast that had trained with them. Now they have a few more since then.
Okay.
And they're not the only company. So it's not to say we're the only pediatric dentist on the East Coast who knew anything about airway. But no, I think that there are plenty of people who are not seeing that, don't know anything about it. But the American Dental Association, which is really supersedes the Academy of Pediatric Dentistry, they've put out bulletins and newsletters talking about the importance of this. And there are many things that we see in the oral cavity that may show up even before the medical professional might notice it. Okay. So it's our role as healthcare professionals to look for certain things that could trigger a diagnosis of something else. In this case, we're talking about airway, but maybe somebody who's got bleeding gum, maybe there's an eruption pattern problem. There are things that we would look for that might indicate, an endocrine issue or God forbid, leukemia, or we check the neck for lumps and bumps. And so, we're supposed to be looking at these things. And so I think the dentists who went to, say, better dental schools were trained with medicine. I know I took almost every class my first 2 years with the medical department. So we get trained in a lot of that stuff. I think Dr. Adams and his school did the same thing as well. So, but I think airway, we will look back on these conversations in a generation, and all of our grandkids will be assessed really early on because the medical professionals will have realized we're heading towards more integrated work rather than separated. We are heading to the point of where, there'll be a medical record that healthcare professionals will have access to see what everybody's looking at and treating and coordinating their care together. It's coming. Mm-hmm. Hopefully it'll come in my career, but it's coming. And so, and that'll be for the better of everybody.
I'm glad you brought that up. Do you feel it's often difficult with that interdisciplinary approach? Often we'll identify issues, but then we refer to, say, the ENT, or the parent speaks to the pediatrician and kind of poo-poos our concerns or what we are seeing. Do you find that you identify, say, something that would be affecting the airway, maybe make the recommendation to the ENT, and the ENT is not in agreement?
It's funny, I haven't found that problem with ENTs as much. You would think most ENTs are like, cut hungry and want to just tank tonsils and adenoids out.
Yes.
And I don't think that's really true. No. I find most ENTs are, if you can figure out a way to fix this without having to do surgical intervention, they'd prefer it. Now, their first line of defense was always medical side, right? Nasal steroids, etc.
Yep.
You know, I just had my son in, who is a patient of yours.
Yeah.
And he did myofunctional for many years, and then I put him in airway appliances as well. And he was in the other day, and I brought in his CAT scans a year apart, and his adenoids are completely resolved. And he was like, "What did you guys do?" And no, I gave him a little idea of what's happening. And so I think ENTs are not the problem.
Okay.
Now, who are the problem? That's hard to say, and I don't want to get in trouble with anything.
Exactly. We don't want this to be servicing for a while.
We don't want to bite the hands that feed us, right? But I think there just needs to be more education in general to other healthcare practitioners, even within the dental community. Okay. You know, the orthodontist had another lecture series about 2 years ago, and the consensus that came out of it was orthodontists are not creating OSA. OSA, for those who don't know, right? Obstructive sleep apnea. And we know obstructive sleep apnea is like the end. It's like the all the way to the right of this is as bad as it gets on sleep apnea. But you can still have, you know, sleep distorted breathing and not necessarily have obstructive sleep apnea. And I think that orthodontists don't want to hear the story that the headgear or the removal of permanent teeth may have contributed to the person's sleep problems and their swallowing problems. And we talk about, you know, your teeth are like a cage. And so we can make that cage beautifully straight. But if we make that cage too small, where does that tongue live? And then you guys come in, and I'm a perfect case, right? I had braces, and I was a patient of yours as well. And you guys kept going, "Get the tongue up there." Like, and you kept sticking things like, "Get the side of my tongue up into the roof." And I'm like, it just doesn't fit. Because guess what? The cage was too small. We actually ended up developing a 6-foot tiger in a 3-foot cage.
Yep.
So, you know, and we don't treat anybody like that. I mean, we joke about it. And Dr. Adam and I have a video series that I think we sent you guys and you watch. And we give the classic example of, you know, a woman who's wearing sandals and her pinky toe is hanging off the edge of her shoe. So what most people would do is they would get bigger shoes. Okay. But for the last, you know, 75 years in orthodontics, they would say, just cut off the pinky toe and we'll get all the teeth to fit in your shoe.
Yeah.
And we're like, no, don't cut off your pinky toe. In this case, don't pull those permanent teeth. Let's get your face to be bigger. And then you'll be able to breathe better, and your tongue will have some place to go. Now, you guys can talk about tongues that are not as strong and they're a little more flaccid, and they just might be flopping around in there, and we can make them stronger and teach them the right places to go. That's really also incredibly important. But yeah, that's you know, that's the gist of it, I think.
Yeah,
No,
I think we definitely agree. Space is key.
Yeah, space is
on
key.
our end, on your end.
Absolutely.
How about patients who have excessive gag reflexes? I know that's a concern of a lot of our parents, of not going to the dentist because they'll never tolerate it. They're so intraorally defensive, they gag so easily. So how do you approach patients like that?
We just send them to you and have you guys.
Perfect. Thanks.
I mean, there are a lot of things that we can do. When the gag reflex becomes a little bit of an issue is, you know, traditionally children get nervous when we're taking x-rays because it's a little bit of a, you know, a bigger film that goes in the mouth. You know, as pediatric dentists, obviously we have certain tools and supplies that are kid-friendly and child-friendly, which is one difference of going to a pediatric dentist versus an adult dentist. But also, you know, there's different modalities. First of all, I mean, when it comes to a filling, sometimes we use laughing gas, nitrous oxide, and that reduces the gag reflex. We have little tips and tricks. We also have something in our office is called a PBM laser. And sometimes if we just put it on a certain pressure spot, it can reduce the gag reflex a little bit, which is very minimally invasive. But we always try to, you know, make a child comfortable and work around it. And usually we can with the different, you know, tools, tips and tricks. A little bit of distraction goes a long way as well. You know, we'll have a kid pick their feet up and take a big smell in through their nose when they're taking an x-ray, things like that.
Yeah, and actually, to add to what Dr. Adam was saying, there are some patients who do have an extensive gag reflex, which almost always means they have a high acid content in their mouth. And so myofunctional therapy would certainly be very helpful there, okay? But for those patients who have a severe gag reflex and their teeth are really, really broken down, you know, we've had patients where we've had to use our anesthesiologist and they're put to sleep under general anesthesia and all of their teeth are corrected. I wouldn't recommend that just for routine cleaning,
Mhm.
But for patients who really have, say 5 to 10 cavities that are pretty significant, root canals, caps, etc. I mean, that's certainly a way to kind of hit the reset button. And then we talk about different types of toothpaste, toothbrushes, etc. But listen, that's why, there's tile in the bathroom, because if you're brushing and you start getting a gag reflux, you're not on carpet. Right? Like, you just gotta
Easy to wipe it up. Easy to wipe
Right,
it up.
exactly. You got to get through it.
No carpet.
No carpet.
Right.
How about flossing? Is there an age that you recommend flossing, and is there any benefit to flossing versus using a water pick or something more mechanical to address those issues?
Well, good habits can never start too early.
Oh, I like that.
So flossing from purely a dental perspective is going to prevent you from getting cavities in between your teeth, and it's going to make your gums healthier. And for the child who has a lot of space between their teeth, some of those areas will be self-cleansing. And for the child, usually when they're around 4, the molars will start touching side by side, and then you really have to clean in there. As Dr. Adams spoke about a little bit earlier, there's that caries risk assessment. Some people just really aren't high risk, and they might say, I don't have to floss. But I would suggest, again, the sooner you floss, the better. And we find that families that floss are families that floss. It's not going to be, I can't get my child to floss. And I'll say to the parents, well, do you guys floss? So, and then listen, on the other side, there's a lot of research that's come out over the last 20 years that talk about flossing and the benefits of cardiovascular disease. So, we've been studying for years, why do we think people have heart attacks? And we looked at cholesterol and the different types of cholesterol. And then we look at inflammation scores inside of your arteries. And a lot of the research has shown that the inflammation that's really caused within your cardiovascular disease can be traced back to periodontal bacteria. So if you can eliminate periodontal disease, you very well may be eliminating cardiovascular disease in the majority of people. So I asked you before, when I say to a parent, at what age would you like your child to have their first ENT surgery? I would ask the general public, at what age would you like to have your first heart attack? Right. And most people would say at no age. Right. So then you probably should start flossing more regularly.
Mm-hmm.
Okay.
What I always tell the older kids is, there's a front of your tooth that's like the belly. There's the back of your tooth that's like the back. There's the top of your tooth that's like your head. And then there's the left and right of the tooth. And not flossing is like going to the shower or bath every day and never washing the left or right side of your body, which is disgusting.
Yes.
So it's the same way it's the way we clean the left and right side of the tooth. So it's the only thing we can do.
He was giving you an under the table cue there.
I put on cologne for the meeting, but I thought we were going to be in person.
Well, I'm blonde and you smell good. That's good.
There you go.
Well, thank you so much for taking the time to do this with us today. I think your answers and just the answers to these questions are going to be extremely helpful to the masses, but definitely to us and to our patients. So thank you so much. And we enjoy working with both of you so much. So thank you. And I hope we can continue to support each other.
Yes. Thank you guys very
Thanks for
much.
having us.
I hope I was able to give you some insight and answer some of your questions regarding myofunctional therapy. Please stay tuned and listen to our Myo Minute and tune in to our Talk the Talk interviews with the many different medical, dental, and rehab professionals as they elaborate or answer your questions and address your concerns directly, especially when it's related to speech-language pathology and myofunctional therapy.